Hello and welcome to today's King's Fund event. My name is Jo Vigor and I'm delighted to welcome you to today's online event where we'll be looking at the subject of tackling cyber threats in health and care in relation to learning from Covid-19. I'd also like to take this opportunity to thank our event sponsors, IBM, for supporting the time today and for making this possible. So before we start, I'm going to briefly explain to you what you'll expect of the next hour and before we turn to our panel for today to introduce themselves. So overall, as we're recording this ahead of time, we've accumulated a list of questions from our audiences during the registration process. We'd like to invite you to, as the audience, to submit more questions via Slido as the event is transmitted. You should be able to see a chat box next to the video where you can submit your questions, and our panel will be looking at these questions and responding during the live broadcast. Okay, so let's just meet the panel briefly. So I'm going to just introduce them to you, and then after our introduction, our panelists will open with some initial thoughts and reflections before we open up and look at the questions that have come in already. Okay, so I'm just going to start with Pete, if you'd like to introduce yourself.
Hi, my name's Pete Rose. I'm the Deputy Chief Executive of NHS Digital, and I also oversee our IT operations, cybersecurity and infrastructure services. I'm relatively new to the organisation. I joined NHS Digital at the beginning of May, so it's been a very interesting and challenging time to join the organisation. My background is as an engineer and technologist. I've spent about 30 years now in that industry, spent most of that time in the public sector, time with the Home Office before I came here, and I originally started my career in the Royal Air Force for 16 years, so a broad range of sectors that I've been involved in.
Thank you, Pete, and welcome. So if we can move to Sarah now, please.
Thank you very much. And my name is Sarah Gafour. I'm the lead for digital health at the Institute of Global Health Innovation at Imperial College. And I'm also a consultant in respiratory medicine at St Mary's Hospital. My role in cybersecurity has evolved over the past couple of years. At my role at Imperial, we've set up the first academic centre for healthcare cybersecurity in conjunction with the Institute of Security Science and Technology at Imperial as well. One of the things that we've seen is that there's been a lack of kind of academic contribution, especially in the healthcare field in cybersecurity, and this is the kind of gap that we have identified and are hoping to fill over the coming years. WannaCry has definitely been the big lesson for the NHS, and certainly there's been huge improvements made since then. And we hope to work with our academic collaborators as well as industry and NHS organisations to help improve cybersecurity for the NHS.
Thank you, Sarah, and welcome. Could we move on to Saif now, please?
Hi, everyone. My name is Dr. Saif Abed. I too am an NHS doctor by background, but I sold my soul about a decade ago and became a partner and director of cybersecurity services at the Abed Graham Group, which is a clinically led global technology group that focuses on healthcare and cyber security. Separate to that, I hold a number of independent advisory roles to the European Commission, the World Health Organization, and the UK's Infrastructure and Projects Authority, focusing on healthcare cybersecurity. And I also have a research focus, which is on cyber warfare targeting public sector health systems.
Thank you, Saif, and welcome. And then let's move on to Dan.
Hi, I'm Dan Taylor. I lead the Healthcare and Life Sciences for IBM Security from our Centre of Competency in Europe. I used to work before that as Director of Security for NHS Digital, bringing to life the Data Security Centre and the National CSOC. One of the draws for me working for IBM is able to travel around the world and learn from other healthcare sectors, learning their lessons, understanding their issues. And I think it gives you a much broader view of the challenges we face, and also a much broader view of the lessons we can learn from other sectors. And for me today, I think we need to discuss that. How do we learn lessons not just from other healthcare sectors internationally, but actually how do we learn from other sectors within the UK that have good alignment, like central government, for example, but also looking at other industries. For example, the airline industry has a fantastic safety culture. And how can we learn lessons from areas like that and bring it into healthcare so we're protecting the patients that we serve and driving better outcomes for them?
Thank you, Dan, and welcome. As you can all see, we have a great panel of experts, expertise and skills with us today. So really would encourage you to chat in any questions that you have, and encourage you to maybe review the film, the recording afterwards as well, and encourage your colleagues to watch as we go through. So we're going to start off with some opening questions to our panelists today. Panel members, please feel free to build on any answers or any reflections that are coming from your colleagues on the panel today. So I'm going to move to Pete first. And I think, what has been NHS Digital's response to the threats that have emerged since the start of the pandemic in March?
Yeah, sure. Let me just give you a few reflections on that. So clearly, our public-facing channels are a really important front door and have been through the whole period of the coronavirus outbreak and the services we offer to it. And we've had to support a very significant increase in the utilisation of some of those services provided by NHS Digital, as well as a number of new capabilities that we had to bring on stream very quickly in terms of support. So in the broadest sense, we've been really focused on maintaining the resilience and availability of those services as part of our NHS Digital operations, I guess. And clearly the cybersecurity response to that is a really critical part, but it's about the resilience of that overall response. And whilst there's a whole range of NHS and other organisations obviously responsible for their own cybersecurity risk, we've been working together really closely to tackle some of the challenges around that based on the insight, the intelligence we have available to us, and then continuing to identify and successfully protect those services, including support more broadly across the NHS. As many people will be aware, we collaborate really closely with our partners, including areas such as the National Cybersecurity Centre, other NHS organisations, to make sure that we're giving them the best guidance that we could over that period. And it's probably worth just highlighting a number of really specific programs we mobilised through this period to improve our response and help help respond as this developed. So from April, we put together a further programme of specific work, working in collaboration with our partners such as NHSX, again the NCSC, as well as our industry partner suppliers, in addition to our own internal organisation. And we augmented our support for monitoring, our local resilience, and mitigation of those specific threats when we could when we identified those, and just a few examples. So for example, we've been engaged really closely with over 100 trusts to help identify any particular additional issues, help where it was needed, and we've got about I think at last count a couple of hundred individual specific tasks and requests in progress with our teams and others to engage and respond to those. And that first few weeks was very much around that identification of particular challenges, and then move into a kind of a sort of a more of a response mode. We've also built up our threat hunting intelligence services that are provided through our Cybersecurity Operations Centre, and we've taken additional input from a range of organisations to help us respond to that, to make sure that we're really focused on where we need to monitor, where we need to respond more closely. And in order to support that, we've actually increased our capacity within our Cybersecurity Operations Centre itself, so we can operate at an increased pace and scale to respond to needs as and when they might have arisen. Clearly, we've been involved in a number of other things as well. So, for example, sort of the networking activity around things like establishing the Nightingale hospitals. How do we set up that support securely across our network services, and worked on some of those things as well. So, really, along all those sort of our day-to-day operation, then we've had to build that capacity and capability to provide support. But it really all comes back to that point of view that said it's part of our overall response to maintain our availability and resilience, which is so critical during this time.
Thank you, Pete. I mean, you've talked there about maintaining resilience, about in the early days, the early weeks of the pandemic, really looking and working with partners to identify the challenges, and then going into response mode. So lots of activities going on there. So I just wanted to move with that sort of context in place. I just wanted to move on to Sarah to really think about the new ways of remote working. So from the individual to the organisation to the system, the new ways of remote working have brought different challenges for all of us in the health and care system. I mean, look at us today. We're doing something today that 2 or 3 months ago we would have thought impossible, or wouldn't have used these channels in this way. So what support is available to enable best practice or good practice, and to reduce the risk of cyber threats at this stage?
Yeah, absolutely. What you're saying, there's been a huge range of challenges for all healthcare organisations from a cybersecurity perspective, and certain features make the health and social care systems a lot more vulnerable during this pandemic situation. For example, healthcare staff have been redeployed within either existing organisations or externally to help respond to the pandemic. And this movement leads to risk in terms of maintaining adequate access controls to IT systems, and also in accidental errors due to working with unfamiliar systems. Staff may also be sharing passwords and smart cards in order to access systems to deliver safe patient care, and this always leads to increased risks. Then there's also been the rapid introduction of new digital solutions to ensure that patients can still have access to care. And like you say, this has rapidly evolved. 3 months ago, if you were to say that actually we're delivering all outpatient appointments, or certainly most of them, by using remote technologies, people would not think that would be the case. But now we're using Attend Anywhere, Accurix, all other digital systems, telephone consultations, and all of these new technologies have an inherent risk of compromising systems. We've seen the video platform Zoom has seen a significant rise in the number of users since the outset of the pandemic, but there's also been a number of security flaws that have been uncovered during that time. In terms of support for all health and social care staff, and certainly for the system, I think it's been brilliant with the advice that's come out from the National Cybersecurity Centre in terms of how to maintain safe working practices. This has also been followed up by NHS Digital as well, in terms of what health service organisations can provide for staff. Certainly our institute at Imperial, we've created a cybersecurity update for all health and social care staff. And this is just to make it really simple and easy, just to make sure it's those basic things that all members of staff should and could be doing, to make sure that the service they're providing is as safe and secure as possible. And I think one of the things that everyone's got to remember is that, whether you're accessing these systems from home or your workplace, we are all custodians of patient data, and it's our responsibility to make it as safe and secure as possible, and kind of following these simple basic instructions just to make sure that you're maintaining cyber hygiene at all times.
I like the cyber hygiene label and logo. That's something that I think we could start to pass on into common parlance. Dan, you had your hand up. Do you want to come in on this question?
Yeah, it was just to say, I don't think the shift that health and care has had, digital shift in the last 8 weeks, should be underestimated. I think, the move to online consultations and such like in the last 8 weeks is huge, and probably that change has been greater in the last 8 years than we've seen greater in the last 8 weeks and the last 8 years. But I also think we should acknowledge that the attackers are noticing that. So if we look at some of the work that IBM's done with our X-Force Red Team, they're the threat hunters. Within 1 month, we saw a 6,000% rise in spam emails utilising the keyword COVID. So what we're actually seeing there is we're pushing more people to work from home in health and care. We're putting more pressure on them to do certain things differently, and change is difficult, and that needs to be managed. And at the same time, we're seeing attackers trying to use our people, our staff within health and care, and use that vulnerability of change to actually, compromise our system and services. And, that 6,000% increase happened within the month between March and April, exactly the time that we were changing the way we work at the health and care system. And not only that, we saw the people the nations originating that spam change as well. So we saw a particular, nation changing from being outside the top 10 to being number 1. And it just shows that what I'm trying to get at really is that at the same time we're making this fantastic digital shift, which we really need to maintain, what we're also seeing is the attackers are shifting the way that they actually look to attack us and actually use some of those vulnerabilities. And I think our role within health and care is to make sure that as we move to this digital shift, we're maintaining that security and making sure that we evolve the way we deliver to make sure that we are mitigating those risks.
Thank you, Dan. So I think that's speaking into that whole point about vulnerability and the fact that this massive shift has happened in the last sort of 8 to 12 weeks. Really speaks to how do managers, leaders and organisations really help ensure, to Sarah's use, have the hygiene factors in place to really understand what they need to do through this period of change. So thank you for that input. And that really sets up Safe's question, which is around what is the future in terms of cyber security and cyber threats? And what can the UK learn from the processes being put in place internationally to prevent them? So, Safe, where are we going? What are you seeing? What are you hearing? Where do you think we should be going, and what should we be learning from?
It's a really interesting point because it follows on from what Sarah has said and what Dan has said, in that the overall threat model is starting to shift and evolve. And I want to illustrate that in a couple of ways. First, we have to acknowledge that across health systems across the world, not just in the NHS, digital maturity has gradually been increasing, in some places faster than others. But security maturity has not kept pace with that. The level of investment in people, processes, and technology has been here, whereas digital maturation has been up here. And that gap between those two has been what has made healthcare such an attractive target. But it's made it attractive for two different types of attackers, if you want to categorize them. One, opportunistic attackers. They now know that healthcare could pretty much be an open goal. So the sheer volume of attacks opportunistically that healthcare providers have to deal with is increasing exponentially, as Dan has just mentioned. And unfortunately, they only have to be successful once to really be disruptive. So that's one side of the threat model. The other side is something I've written about for some time, and that's the more targeted attackers. And they now understand what the concept of clinical urgency is. They know to get what they want, whether it's a ransom payment or to just cause really significant disruption, they need to target the most acute clinical services, whether that's emergency services, A&E, medical wards, ICU, operating theaters. Generally, the approach of targeting the most acute areas pays the greatest dividends for them. And that's a really interesting evolution in terms of cybersecurity, because you have a huge volume of unsophisticated, opportunistic attackers that the average healthcare organization has to deal with. Layered on top of that is a more sophisticated attack base as well. So it's really challenging. And a further thing I've written about for some time, which perhaps is even more worrying, is how the type of attack is going to evolve, actually. So we all know about ransomware. You lose availability to your systems. It's bad, but at least you know about it quite fast. I wrote about something called a clinical integrity extortion attack a couple of years ago, where I said, instead of just making systems unavailable, what if you mixed all the clinical data together? So imagine taking lab data and shuffling it between patients, imaging data, radiology reports, resetting early warning systems to normal. That's really insidious, because unless someone notices something's off and raises a clinical alarm bell or a technical alarm bell, or the attacker themselves calls you and tells you, we're shuffling everything together and we're going to persist and keep doing that until you pay a ransom, that's really scary at that point. And we've actually seen studies from Ben Gurion University in Israel where they used a type of malware that put fake cancer nodules on CT scans. So it's definitely in the realms of possibility. It is where the threat landscape is moving towards. So greater sophistication, greater volume, and scarier attacks, frankly. Now, I don't say this to fearmonger. I say this purely to highlight how the cyber attackers are always trying to get one step ahead. So that's where I think we're heading, and I think we need more academic collaboration with organizations with Imperial, other universities. We need more government agencies on the healthcare side to collaborate with the intelligence community, and industry has a critical role to play in this as well. We need more companies in industry to start thinking, okay, we don't want to just sell technical products. We want to look at patient safety outcomes. We want to look at how we can fit into this evolving landscape. So it's a tough question you asked me, Joe. There's so much to dig into, but I hope that's given you a bit of a feel as to where security is heading in healthcare, at least from our perspective.
Thanks, Saif. And I think I want to come on to a question later with you about moving away from the technical piece. What does this, as a manager or a leader or a member of staff in the NHS watching this, what does it really mean for me? And you've just started to touch the top of that iceberg with that example you gave there about the ransom and the shuffling of potential patient data, etc. So let's come back to that in a moment. Just before then, I'd just like to come to Dan. And really, Dan, the question that we want to start with you is, what are the key opportunities COVID has presented for better integrating cybersecurity strategies into organisation and system plans? So how do you bring this all together?
Okay, so I think COVID has affected all of us, especially me personally, my family. So I hope everyone is safe and well who listens to this. But I did want to touch on more of a positive area of COVID, which is that, and I mentioned it before about digital shift, in that we've done more in the last 8 weeks in terms of enabling digitization than probably we've done for a long time within health and care. And it's absolutely our role to make sure we maintain that moving forward. And one of the things that concerns me is that we have a propensity to look for a zero risk kind of implementation of everything within health and care, especially where technology is concerned. And I think we need to move away from that. And I'm absolutely clear, both when I was in the NHS and IBM now, that, you know, we really need to focus on the benefits of what we do. Security's role is not to say no. It's how do we do this safely? And you know, when you look at it, we need to start changing the conversation away from cybersecurity more to patient safety and patient outcomes. So, you know, if you look at the CQC report from 2018 on emergency care, 74% of all attendees at A&E had a diagnostic treatment, and the majority of those were imaging, and imaging is digitized across the NHS. If we were to lose the digitization systems from across the NHS, we wouldn't be able to treat the patients through A&E. And suddenly it isn't a cybersecurity issue, it's a patient safety issue. So if you lose your radiology system through a cyber attack, it isn't an IT issue. It's about the ability to treat patients. It's about the ability to drive better patient outcomes. And we need to start talking in that language. And it's that balance of risk. So we operate on people. We make an operative intervention because the benefit outweighs the risk of doing it. And it's exactly the same here. When we're moving to digital systems or digital, appointments or other interventions using digital technology or video, whatever it may be, there is a risk, of course, to doing that. And our role in security is to enable that and to make sure we are doing it in a secure way. And I think it's really important. You know, the Mayo Clinic did a study and they found that when they used Internet of Medical Things, medical devices particularly, in their treatment, they saw a 40% reduction in readmission of patients. And when you think about that for the NHS, which is under strain at any particular time, using that technology, reducing the admission rates is a fantastic benefit. There is absolutely a risk to using technology, but our role in health and care is to work with the right people. NHS Digital's Data Security Centre has some fantastic people and resources and do brilliant things. The National Cyber Security Centre supports it. There's great industry partners out there, like Saif's mentioned, and we need to link academia. But we shouldn't not implement new systems and services because there's a risk to them. We need to look at the risk balance. We need to look at that risk and mitigate it. But ultimately, if it's for the benefit of patients and it drives better patient outcomes, then our role in security should be, how do we do that safely? And for me, I think that is absolutely key in how we move forward, in looking at it on that risk benefit, understanding why we do what we do, and driving that forward. And I think it links to my point earlier, which is about culture and learning from other areas. So we need to make sure that we learn from people like the aviation industry, who has a really good security culture, a really good, honest, transparent reporting culture of near misses and incidents. And that is where health and care needs to be in this space. And the team in NHS Digital did a great job of changing the information assurance regime, the data security protection toolkit. So we actually went from being punitive, if you were honest about where you were and the level of security you had, previously you might have been punished for that. But now under the new regime, it's a great start. You then can have an action plan. You can build on the action plan. And it starts with the idea of knowing your risk, knowing where you are into your maturity, and then building on it. And I know security can seem very daunting for health and care, but I think it starts with understanding where you are and building upon that as you move forward. And it just really, we've got a fantastic opportunity, moving forward to seize the nettle on what we've done over the last 8-9 weeks, and to take some real positives out of COVID. And I do not want security to be a barrier to that. It's how we do it safely. And so for me, let's carry on doing what we're doing. Let's, of course, secure what we're doing. By securing it, we build patient trust, we build patient confidence. We'll be able to expedite that rate of change, but more importantly, we'll drive better patient outcomes and be able to, have a better patient experience.
Thank you, Dan. A real sort of impassioned call to action there in terms of changing the language and the framing of some of these conversations right into the heart of what matters for people around patient outcomes and development of the workforce from that point of view. So we are going to move on to some of the questions that have been sent in ahead of this pre-recording. But before we do that, I just want to move to Saif and then Sarah, just to ask you, in terms of building on from what Dan was saying, if I, as a manager or a leader in the system, why should I pay attention to this? What other nuggets or information would you like to share with our audience today about why this is so important based on the work that you've been doing? Could I move to Sarah first and then on to Saif?
So I think it's super important for managers and leaders to kind of ensure that cybersecurity is a fundamental core part of our patient safety offering. This has got to be seen, as others mentioned, this is not just an IT problem, this is a patient safety issue. And we've seen the repercussions of that from WannaCry firsthand. And it's really how we build on this. And actually, one of the really exciting things is the fact that digital technologies can offer new ways of working and can address some of our kind of big healthcare problems in terms of access and availability of healthcare. As we move forward, we've got the opportunity of, we've got emerging challenges for the new devices and the new IT solutions that we bring forward. For example, connected medical devices, AI and algorithmic decision making, more, bigger use of robotics, precision medicine, cloud computing. All of these things are super exciting and can really make a big change for the way that we provide healthcare. But at the same time, they all come with their challenges in terms of security. One of the big things is, a great ambition would be for patients to have access to their healthcare records as well, so that they're an equal part of their care. And to do that, we're bringing in another vector of potential attack. It's again a vulnerable system as well. But I think that is, the way forward for everyone to have access to their own records. But again, all these things bring challenges with it. But the whole situation is to really look at it and to make sure that cybersecurity is fitted in right from the start, and it's not something that's retrofitted with a lot of the legacy systems that the NHS and other systems do have across the board. And again, we are all kinds of patient data, anyone who works in the health and social care landscape. I think, again, one of the things that is fundamental to any of this is trust from the patients and the public. It takes one cyber attack, one cyber breach or data breach, and that trust is absolutely eroded
So, Saif, I'm going to move on to you to build on that. So, obviously, Dan was there talking about the appetite for risk in terms of the work and in terms of really thinking about the risk benefits and the culture of learning. Sarah has talked about bringing in cybersecurity fitted in from the start rather than retrofitting, so it becomes part of your thinking. And then, say, from your work internationally, what advice would you be giving around to managers and leaders about making sure this is about patients being at the centre of this? Thank you.
Yeah, I mean, there's a really important point here about why this matters and why it's problematic. If we continue to maintain a conversation in healthcare where cybersecurity is about a vendor, selling a solution that's given to a network manager who's underfunded by themselves in a major hospital to manage and run, along with 10 other solutions that they've accumulated over the last decade, it becomes purely a technological conversation. It's almost like security is siloed by itself away from even IT, which is then siloed away from medical engineering. And that's tremendously problematic. And that one person really will struggle to do much unless cybersecurity is not spoken about as cybersecurity. It's spoken about as patient safety, care quality at the board level, at the executive management level. If that buy-in, if that language isn't there as a part of the annual strategic review, the quarterly strategic review, there is very little, even the most well-meaning, sophisticated, research-focused network manager will be able to do, because they don't have that support. And I see that in every country that I've been fortunate enough to work in, every multinational project that I've been involved in, if that top-level leadership is not engaged from the outset and purely uses the word cybersecurity, it becomes, unfortunately, downgraded into another subsector of IT, and it doesn't really go anywhere. So that's a really important point, I think, that needs to be addressed. But then, in terms of actual how we look at risk, both Sarah and Dan raised a really important point. Well, we can't get rid of every risk. There's going to be residual risk. And one of the biggest issues around vulnerabilities in particular is that, I think we can all attest to this. The average public sector hospital, if they scanned and discovered every device on their network, they would be inundated with potentially thousands of devices they weren't aware of, with tens of thousands of vulnerabilities. And it's frankly overwhelming. So how do we figure out which vulnerabilities are the ones that actually create a patient safety risk or a risk to disruption of clinical workflows at scale that have ramifications throughout the hospital, but across neighboring institutions as well? That's something that we've done a lot of work on at the Abed Graham work with an analytics platform we developed. And it's something we've worked on with IBM in terms of applying it in a few research areas about looking at technical vulnerabilities and analyzing them and recontextualizing them in terms of patient safety impact. So I think new ways of thinking, even in terms of the technology that a healthcare organization uses with a view to being more focused on clinical impact and clinical risk, is really critical. And then just one final point. We actually have something in the NHS that I believe is the envy of the world in terms of regulation against cybersecurity. It's just that, I'm going to say it directly here, it's not implemented and policed enough. We have an entire standard called Clinical Risk Management for Health IT, which basically says every NHS trust and every vendor should have a clinical safety officer who is reviewing the risk status of projects and products that are coming into deployment. This is a tremendous standard, and we need to make sure that both industry and healthcare providers are adhering to this, because it takes the singular focus of something very technical and puts it completely through a clinical lens. So I'm going to pause there, but those are my viewpoints on this.
Thank you very much, Saif. Lots to think about there. And Pete, you wanted to come in on this.
Yeah, I think both of the last 2 points really kind of hold all this in balance in terms of understanding how you tackle this problem from both a development perspective and from a clinical perspective right from the outset of bringing these new systems and services into being. So, we've seen plenty of examples over the last few weeks, as I mentioned at the start, but some other great ones here as well. And actually, if we're having that conversation from a clinical utilization perspective, what are the use cases, what are the service journeys going to be at that design stage, then we can have a much better chance of making sure that secure, resilient, safe services are built in from the outset. Typically, of course, when organisations are under pressure, new things have to be brought in at short notice, etc. It's that much more difficult to put the basics in place at the back end of that project or program or whatever that journey that we have to deploy at short notice. So I think, as you said, Safe as well, really good clinical practice and governance, so that clinical safety cases, clinical assurance, etc., is built in alongside the security aspect right at the outset. Means you've got a safe journey that you're not trying to retrospectively fit, and we've had some good examples of that even in the last few weeks of things we've deployed. So that makes the whole challenge a lot more straightforward than trying to bolt something on at the end of this conversation.
Thank you, Pete. And I think that leads us quite nicely into one of the questions that has come through from people that will be watching this as it goes out, and that is around what learnings can we take from other sectors to enable better preparation for future and evolving threats. But Pete, I'd like to start with you, because I think we were chatting earlier about the fact that the NHS shares many common grounds with other public sector organisations, and I think it would just be great to get an idea about some of the work that's going on across the public sector before we move into learnings from other sectors and other parts of the markets. So, Pete, if you could come in on that, that would be fab. Thank you.
Yeah, certainly. So, as you said, there's clearly any organisation's got some unique features, and some of the things we just talked about earlier. But some of those things are also, very much common, have a common ground as well. And I think a lot of that is about understanding what we've learned from other organisations and other parts of the public sector about making those the correct risk judgments from the outset, and then focusing on particular capabilities that we can actually share, reuse from other parts of the public sector and our partners and beyond. So quite a lot of what we're deploying and our protective monitoring, some of our more technical capabilities are not hugely unique. There's some, the good common standards. A lot of this is about good protective monitoring. It's about making sure we're designing good network architectures, good security architectures around this. There's a lot of common components that we've already deployed in other sectors and learned here as well. So actually, in many cases, those things can be reused, and of course we have the benefit of being able to be very, very free to kind of share our learning, not only in the health and social care system, but actually with partners in other parts of the public sector, free from sometimes that competitive edge that is positive in many respects, but sometimes it can be a bit of a barrier to people sharing what they've learned, what went well and what didn't go so well. And I was really taken by Dan's point earlier, having, I guess, started my career in a world where aviation safety also was really important, because that ability to kind of share what you've learned, what's gone well, what's not gone so well in a confidential setting, actually means that those things can be identified and you can do them better next time round. And I think that that's a really good key feature of how we would have worked across other public sector organisations to do it. Again, the National Cybersecurity Centre is there, of course, for both public and private sector usage for to make the UK more generally safe. But some of the relationships we have with those organisations and what they learn from other government organisations and government sectors, be it in transport, health, etc., means we've got a really good organisation and a really close community that can share those things together. So I think really making use of those across a number of organisations really brings dividends, rather than everyone sort of looking at it in their own domain and trying to guess what's going on elsewhere. So I think that's a real bonus for us.
Thank you, Pete. So lots of strong messages there about reaching out, collaboration, learning from each other. Don't feel like you're on your own in this, in terms of the challenges going forward. So could I just come across to Dan and to then to Safe just to learn a little bit more about your work in industries and internationally. And Dan, you've mentioned the airline industry a couple of times there, who've clearly been on a journey themselves. Could you just elaborate for us, Dan, a little bit more about some of the learnings from that sector or from others that you have uppermost in your mind? Thank you.
Yeah, no problem. I think that what comes to mind straight away from Pete's comment is that health isn't unique, and we need to move away from that. There are differences between every industry, but everyone is kind of facing the same problems. And I think we need to break down that point in that we do need to ask for help or look across to other industries. Of course, there is no bottom line of the balance sheet. We're talking about patient outcomes. I get that, but ultimately we need to learn lessons from other industries, and I'll come back to airline in a minute. But what has taken me aback a little bit, I guess, and it's a mea culpa here from industries. We've got a responsibility as well to stop selling the panacea to health and care organisations. There is not one thing that is going to solve the problems across health and care. It is a multi-layered approach, and it goes back to my previous point on, we need to understand our baseline, where our vulnerabilities are. We need to prioritize those vulnerabilities. And then we need to have suppliers who can, honest brokers who come across and say, we can help you with these areas. This is your priority. We can help you with this. And we need to be, and this is what I've learned from other sectors, is the health and care system needs to be, unfortunately, more intelligent customers in many ways. And I don't mean that disrespectfully, but I think we only have a very limited spend across health and care for this area. I think linking it to patient safety is key. I think, as Safe said, it'll open doors in boardrooms. We should be mapping clinical risk. But I think if you look at other industries in terms of financial services, they're much more savvy about where their risks are, what they need, what they want to buy, where they believe different suppliers can play and what they can offer. And I think the first thing we need to do is help our healthcare organisations understand how to work with the supply community better, help them understand their risks and that baselines I mentioned, and then go out to market in a more intelligent way for more bits of the pie almost that they need to secure their organizations, because there isn't one thing that's going to solve it for them, but ultimately they need to prioritize on risk. And what I also think we need to do, and having worked out in the Far East recently, we need to move away from almost what I'd call point solutions, where actually a certain sector or industry or nation has had a healthcare attack, and they've gone, okay, what we need to do is buy something that stops that attack, when actually that may not be the most important thing that's happening. And so there's a lot of work, Peter probably had to talk more, that NHS Digital are doing at the moment in terms of identifying organisational risk, in terms of their cybersecurity support model, how they're helping to prioritise that risk. And I think it plays into that. We need to make sure we're being intelligent customers with the right information, not just buying solutions because we've been attacked in that way. We need to look at it more in a strategic way, and we need to build security. And as Pete said previously, at the get-go, it's much harder to build security in at the end of a project. And also, aviation's key for me, because it's the transparency that's hugely important. And it's analogous, because a failure in safety in the airline industry is directly going to affect the safety of the customers in the air, on the ground, wherever it may be. And as Pete mentioned, they have a fantastically transparent reporting culture, an anonymous reporting culture. They act on it. They have different bodies that work together. Whether it be Civil Aviation Society or NTSB in the United States, etc., that cooperate. So there is international cooperation between those lessons as well. And so not only they've got transparent culture, got a great reporting process, they act on it, they share lessons across different areas internationally. And for me, that's where we need to get to. And so to wrap that up, really, we need to be better customers and consumers. Equally, industry needs to stop selling the answer, because there isn't one answer, and we need to work together on that. We need to help our health and care organisations understand the baseline so they can buy appropriately with the right information. And we need to create a culture across the NHS where it's okay to say, I don't know, or I need help with, or there is a problem here. And then when you're reporting that, we help them with the answers, and then we're flowing that information not just across the NHS, but to our partners internationally to build better cybersecurity, but more importantly, secure those patient outcomes and secure that patient trust that we keep talking about.
Thank you, Dan. Really comprehensive answer around, especially drawing on the experience from the aviation industry. Safe, I wondered if you could build on that but with a reframing slightly of the question, which is there's lots of activities happening globally in the cybersecurity space. And I think Dan touched on there about the NHS becoming a much more intelligent customer. So how can we encourage the NHS to tap into that international resource and knowledge, whether that's through public sector services globally or through the commercial and private sector, to really help the NHS in its learning and to make that shift into some really great intelligent customers and intelligent buyers?
Yeah, so there's some interesting points here. I mean, if we pick a specific example, let's look at medical devices or IoT. And it's always interesting because from my perspective, IoT, anything that's internet connected is by definition IoT, but in healthcare, it seems to get pigeonholed into specific medical devices. If we look at, say, the US, the FDA has been issuing advisory guidance for some time about cybersecurity best practice around medical devices, what is considered clinical harm and what isn't. The European Commission has the medical device regulations, which go fully into force next year. They've been postponed by 1 year. Japan and Australia have developed their own versions of that. Clearly, here we have MHRA. And these are all different agencies at different levels of their maturity in terms of how they issue regulatory guidance. And that's interesting because at some point, the suppliers of the medical devices and their underlying security posture are operating across multiple geographies all at the same time. And so what the NHS needs to do in many ways is conduct an exercise where they say, okay, which version of a regulation is the most commonly deployed? Because a lot of these are still in their infancy, these regulations, or they're still advisory in nature. So the NHS needs to decide which one is going to become the global standard, or if they all look slightly different, which one do we believe suits our healthcare system and our level of maturity the best? Because that then dictates the type of conversation that ends up happening with industry, with medical device manufacturers, with security solution suppliers, with even systems integrators. And so that's a really important point in terms of how we involve global collaboration. But on another level, there is the whole notion of we need to know what's out there in terms of vulnerabilities and threats. What vulnerabilities are being exploited, which vulnerabilities are becoming attractive for attackers when they target health systems, and how serious is this? And I think the NHS has a really interesting position where it could actually be a leader in terms of taking the entire conversation, flipping it on its head and saying, okay, we want to look at these vulnerabilities, but not just purely from which one is technically the most severe, has a CVSS score of 9.8, and it has, X company, X hacking group with a funny name like Funny Bears or something is actively going after this. Instead, they could say, this vulnerability, we've worked with some vendors, we've assessed it, and it presents a clinical risk to patient safety of 7 out of 10. So actually, it is quite high. Or actually, we're overplaying this. It may be a 9 out of 10 technically, but it's actually a 3 out of 10 clinically. And here's why. Taking that clinically led approach to analyzing the vulnerability and threat intelligence could be really powerful. It could be I believe it's a game changer. It's where I work in terms of a niche. But I think that viewpoint could be something that puts the NHS as a leader in global collaboration and thinking in this space. So I think that's a great opportunity.
Thank you, Saif. So some really interesting reflections there about how the NHS could tap into what's going on globally and internationally. And I just wanted to move us from the global level, that sort of, what's happening in industry, what's happening across the planet. But let's bring us back into the whole area of what could be happening at an organisational level in the NHS. So one of our questions that we have been sent in ahead of the recording was really about where somebody's asked, we think we've done everything. in terms of setting up the right systems, putting our staff training in place, etc. What else could we be doing? What if we think we've got some of those bases covered? I just would like to just go around the panel for a couple of points each from you about, you've touched on some of these areas, but just to re-summarise, what else could people be doing within their organisation or across their local system? So, Pete, do you mind if I start with you, and then we'll just go around the panel just for those reflections?
Sure. I mean, I think I would say, although at one level, is that the whole kind of capability that we're deploying, is always evolving. And, again, as we've said earlier, we've heard in the last few days and weeks, new things coming to bear. So I don't think, any organisation would ever want to say, yes, we've actually reached that point, we're okay. So you need to be continually looking back on where you've got to, what new capabilities, what opportunities are emerging, and actually kind of checking and rechecking where, even if you think you have got to that kind of position where you want. That said, there are some really leading areas of practice, across all sorts of different organisations, and some of the things we've put in place. For instance, we've fairly recently established our regional engagement leads across, across the system, to be able to kind of connect up with those that have got leading practice to share with others, and therefore that they can then bring others along with them. So I think a lot of this is about continually reviewing where you are and continually sharing what you're doing, so that other people can benefit and exploit it.
Thank you, Pete, for those insights. So, Sarah, what would your reflections be if you were in an organisation today, 12 weeks in?
Yep. So in terms of that, I think for all organisations, there's a difference in terms of how security conscious they are. So that you've got some who are right ahead of the curve. But I think awareness and education are the key points. Even with the email threat can be up to 30%, and this remains the most common source of kind of ransomware attacks. In terms of education for all staff, everyone in a kind of health and social care organisation is mandated to do the information governance module on a yearly basis. This has got a few points in terms of cybersecurity, but I think this needs to be a lot more comprehensive and perhaps be a standalone module in its own right. However, we're competing with lots of time in terms of doing mandatory modules. And there needs to be much more awareness right from C-suite level down to frontline members of staff.
Thank you, Sarah. So a real emphasis there on education at the local level and across your local system. Thank you. So could we just move to Dan and then Saif on this question about what would the couple of things that you would advise people to be really focused on in the here and now at that organisational level?
I think the thing we need to do is not see cybersecurity as an initiative or a campaign. One of the things I always worry about is, cybersecurity over the last few years has had a particular focus. And it can seem, I'm not saying we'd ever make cybersecurity sexy, but I'm saying that actually we've kind of really focused on this as a particular issue. And when you drive it in that way, it can seem a bit faddy, and we need to stop that. And I think Saif mentioned about getting it as a part of clinical risk, mentioned about getting the boardrooms, is that we need to almost normalise this, right? And my view is that my hope is in 2, 3, 4, 5 years' time, we're not talking about cybersecurity as an aside. We're not talking about a cybersecurity strategy. We're talking about cybersecurity being part of an organisational strategy or part of a patient outcome strategy. It's part of another thing. Of course, it's there, but actually, it's just normalised. It's just what we do. And I look at it almost, the clean ward campaigns back in the early 2000s or late 2000s, and the idea about, washing your hands in wards and how we regulated visits into hospitals. That was a campaign that's been completely normalised. Now we take that for granted. And I think we need to do the same with cybersecurity. So for me, it's just making sure that we are ingraining it in our organisational culture and making sure that we don't see it as an aside almost, and linking it back to everything we do. And the other point, which is really a quick one, is to make sure that when we're looking at cybersecurity, that we're looking at it very much as patient safety and patient outcome driven, because we need to talk in a language people understand in health and care. And when we talk about firewall rules or, you know, different monitoring solutions or whatever it may be, right, people switch off. It has to be relatable. So you don't need to know the what almost, you need to know the why. Why are we doing this? Well, we're doing this because if we put these controls in place, we'll make sure our digital systems are safe. We'll be able to treat patients, drive better outcomes. And so it's just that I think it's really important to speak in a language people understand, drive the why of what we're doing. And I think that will just be a bit clearer. And also on that point, there is never going to be a point where you're completely safe. And you may be in control of things you know, but there may be things you don't know. And I think it's making sure we're consistently taking the right assessments, that we're understanding where our baseline is. And it's like, I have a regular asthma checkup, right? I have asthma, that changes, right? And it's the same with cybersecurity. We need to do a checkup on our cybersecurity every so often to make sure it hasn't changed, it hasn't gone down or gone up, depending on which you look at it. And then we can actually treat, you know, almost like a prognosis and diagnosis. You know, we could treat cybersecurity like we treat my asthma by having it a checkup, putting the right things in place to stop it getting it worse, and then making sure that I'm safe and cybersecurity is in a good position to make sure wider patients are safer and we can deliver that care.
Thank you, Dan. I'm just going to pass over to Saif now for your couple of comments. Thank you.
Yeah, so it's really interesting. In cybersecurity, we have this basic concept of prevent, detect, respond. And the same applies in healthcare, but it's kind of the other way around. In healthcare, we're really good at responding. When people become sick, we treat them. Detection is kind of okay, but prevention is not good enough in healthcare. We want to keep people in the community and keep them well before they need hospital care. In cybersecurity, it's the other way around, where, you know, the industry is constantly flogging preventative technologies, firewalls and, you know, anti-malware, antivirus, some level of detection, but not that much focus on response. And so if I bring these two worlds together, I make a very stark and direct comment. If you think you've done everything for your healthcare organization, I'm going to ask you one question. Do you have a clinical incident response plan? Because at some point, your system will be taken down. And when the PACS system isn't working, or the lab system isn't working, or the A&E EHR system is inaccessible, do the clinicians in the department know what to do so that they can maintain a certain level of quality of clinical care without access to these digital systems? And the default answer cannot be, well, actually, our focus technically is to get our backups up and running, or we need to stop the spread of ransomware, so we need to unplug all our other IT systems. Having a purely technical response is not good enough, because in that moment, there will be a time difference between you getting the technical resolution and the systems, the clinical systems, failing. And at that gap is where harm will happen. So do you have a well-rehearsed, drilled clinical incident response plan that clinicians have been briefed on, have been engaged with, have bought into, and it's regularly maintained as being up to date? If you say yes, and here is this document, and it hasn't been sitting on a shelf gathering dust for the last 5 years, it exists and people know about it, then I'd say, yeah, you've done something fantastic there. Because as amazing as the industry thinks it is, we can't prevent everything. You will at some point be hit, and potentially hit quite hard as a healthcare organization at some point in the future. So you have to be ready for that. So that's my view. Clinical incident response plan, clinical safety officer. Do you have those things? That's a good position to be in.
Thank you, Saif. So we've got some really pragmatic responses from our panelists there about some of the things that people can make sure they're focusing on in the here and now. So I'm just going to move on to our closing remarks as we come to the end of this broadcast. And I just want to remind people that you can follow some of the discussion on this on #KFOnline, and would encourage you to maybe continue to chat your questions in. We will be passing those questions on to the panel members as we beyond today, and we'll be looking to get responses from our panel members and others in order to come back to you where we can and where we've got some common themes coming through. So I just wanted to get to our closing remarks part now, and I just want to ask each speaker just to share a reflection from what you've heard today and any final comments. So could we start with Sarah at this stage? Thank you.
So biggest reflection is the health sector becomes even more reliant on IT to deliver patient care, as we've seen in the past couple of months. There needs to be adequate investment of resources and contingency plans in place to minimise harm and disruption to patients in the event of any. I think all of these across all different settings, including low and middle income country settings. What we need is a commonality of language as well, so that we're all kind of working on a same basic framework. And then further, we talk about the impact of cybersecurity being a threat of patient safety. At the moment, the work that we have done has been very much looking at mortality data, certainly from the WannaCry attack, but we need to do more work to appreciate the true impact on care delivery and how we actually measure the impact on patient safety in the event of an IT failure or a cyber attack.
Thank you, Sarah. So I'm going to move on to Pete now. Thank you.
Yeah, I'd echo many of Sarah's points. Actually, clearly we've got a much broader reliance on our services, particularly in the light of what's happened, and really right across the whole of the health and social care system. And that dependency and reliance has really been there. But it's also been a huge, opportunity to be able to use some of those capabilities that we've deployed over the last few months in order to keep those safe, secure, resilient. It really, for me, comes back down to the basics. So, good design from the outset, making sure that we're considering all aspects of this, training, user awareness. It's not just about, very, very high-end technology capabilities here. It's about making sure that whole set of measures is put in place, and we stick to those basics and make sure what we're deploying continues to be safe.
Thank you, Pete. So could I move to Safe now and then on to Dan?
Sure. So, my biggest takeaway is just look at the panel we have today. We have leadership from a government agency. We have leadership from one of the largest suppliers in the world. We have leadership from a leading academic institution that's also a practicing clinician. You have leadership from a specialized clinically based technology organization. And we're all talking together and we're hitting on the same themes. So we should be able to collaborate from all these different sectors in this panel session should be reflective of how the diverse stakeholders should be able to collaborate at an individual trust level, but also at the national level. So if we can maintain that moving forward and push that kind of conversation at the leadership level, then we're gonna be in a good position moving forward.
Yes, some great words there around the collaboration. Thanks, Safe. And I'm just going to move on to Dan. Thank you.
Yeah, Safe has completely stolen my words as per usual. So thanks for that, Safe. No, I think, joking aside, like academia, clinical, central government leadership, industry are all saying the same things, but they all bring different expertise and different backgrounds and contexts. And it's how we work together in future to take what we've done and talked about today and to go, well, actually, we're all kind of in agreement. How do we move that forward? And the other thing is, I hear a lot that it's about people, process and technology. Actually, it's about people. People define process, people buy and design technology, and therefore it's about culture. So our role here is to change the culture in which we work to make sure cybersecurity, as I mentioned before, is seen as just the fabric of what we do. And if we can drive that cultural change, I think everything else will fall into place.
Thanks, Dan. Some great words and some great wisdom from our panel members there. I think we can all agree we've had some great, rich insights into cybersecurity today and the importance of putting patient safety and patient outcomes into the centre of that. And we've got understanding about what's happening internationally, how people can tap into some of those learnings, and some really pragmatic points that people can take away from today as and start to think about and maybe share where they've already done some of those things with others in their community, within the health and care sector and across the public services. So I think it just leaves me to say thank you very much to our sponsors, IBM, for enabling today's online event to go ahead. We're much appreciative of that. And also to encourage all of you to really share the link to this recording to other people, both in the cybersecurity community across health and social care, but also to other managers and leaders to really start that education program that Sarah was talking about there. And I think the last thing I wanted to say is that there will be some short questions that appear at the bottom of your screens, asking people for your feedback. We always want to understand and improve on how this experience has been for you. So if you could take a little bit of time just to answer those, that would be fantastic, so we can continually improve our services. So I'd like to thank our panel for today. I would really like to really insightful and interesting conversation. So we'll leave it there. Thank you very much.